Good evening and welcome to our third CUSD Family Evening, which we are proud to offer in partnership with Hoag Hospital and the Aspire program in Irvine. I'm Ryan Burris, Chief Communications Officer for the Capistrano Unified. Tonight's event is being live streamed. This series is titled Helping Teens and Families Navigate Mental Health and Illness. We're honored to have the opportunity to host and to discuss these critically important topics that we know come up whenever we're out talking to parents in the community at PTA events and even at our board meetings. Tonight's session is about self-harm and suicide. You'll hear from a distinguished panel of teen mental health experts from Hoag, including our featured speaker tonight, Dr. Sack, an addiction psychologist and mental health expert. And during the panel discussion, we'll invite Stacylin Cervantes and Celia Quinn-Levin up to join us on the panel. Both Stacylin and Celia are licensed marriage and family therapists for Hoag's Aspire program, and they will further introduce themselves when we open the panel. After the panel presentation, we'll open the discussion to the audience questions. There were cards when you entered the auditorium, and if you want to fill those out, we will take those during the panel discussion and go through those questions. We will talk with Dr. Sack, Celia, and Stacylin at that time. It's now a pleasure for me to invite Capistrano Unified School District Superintendent Kirsten Vitale to say a few words.
Thank you and good evening. And thank you, Ryan. Thank you all for being here tonight. Tonight is our third evening with Hoag Hospital and their doctors and staff from this incredible Aspire program. We've really appreciated this partnership and this learning together. This school year, we committed to our CUSD families that we would bring these very hard and sometimes uncomfortable conversations out in the open. This year we've talked with families about social media and emotional wellness, vaping and substance abuse disorders, and tonight, self-harm and suicide. This is not an easy conversation to have, but it's so important for our young people and for our families to be able to have these conversations. So we're so proud to have partnered with experts from Hoag to shed light on these important topics. We'll hear from Dr. Sack tonight, who is a highly sought media expert who's appeared on Dateline TV, Good Morning America, The Early Show, E! News, The Doctors, and many other outlets. He has also been interviewed and quoted by the major print media, including the New York Times, the Los Angeles Times, and Time Magazine. So I ask you to please join me in a warm welcome for Dr. Sack and our team from Hoag.
Hi, can everyone hear me? Great, okay. So first of all, thank you to the Capistrano Unified School District and Hoag Hospital for inviting me tonight. And thank all of you for coming out. I know it's never easy in the middle of the week to make time for a series like this. 25 years ago, I was the Chief Medical Officer for an adolescent treatment company called Aspen Education Group. We were a national company. We had programs all over the United States. And it was interesting for me to revisit over the last several months how our understanding of suicide in teens has changed from where it was 25 years ago. We're going to talk about some of that tonight. I'd like to start off, though, with a video clip from a movie called The Sunset Limited. This movie stars Tommy Lee Jones and Lawrence Fishburne. And in this movie, the setup is, before it starts, Tommy Lee Jones has thrown himself off of a subway platform, and Lawrence Fishburne's character is working in the subway and happens to catch him. And not knowing what to do, he takes him home to his apartment. And this is their first conversation about what transpired.
I got to say, you was kind of hard to ignore. Your approach was pretty direct.
I didn't approach you, I didn't even see you.
What I don't understand is how you come to get yourself in such a fix.
Yeah.
You all right? Did you sleep last night?
No.
Oh. When did you decide that today was the day? Was there something special about it?
Well, today is my birthday, but I certainly don't regard that as special.
Well, happy birthday, Professor.
Thank you.
So you seen your birthday was coming and that seemed like a good day.
Who knows? Many birthdays are dangerous, like Christmas. Ornaments hanging from the trees, wreaths from the doors, and bodies from the steam pipes all over America.
That don't say much for Christmas, do it?
Christmas is not what it used to be.
I believe that to be a true statement. I surely do.
How can I go?
You always put your coat on like that?
What's wrong with the way I put my coat on?
I ain't saying nothing was wrong with it. I'm just asking if that's your regular
I
method.
don't have a regular method, I just put it on.
Mm-hmm.
That's what, feminine? What?
I'm just studying the ways of professors.
Well, I gotta go.
Let me get my coat.
Get your coat.
Yeah.
Where are you going?
Going with you.
What do you mean? Going with me where?
Going with you wherever it is you're going.
No, you're not.
Yeah, I am.
I'm going home.
All right.
All right, well, you're not going home with me.
Sure I am. Let me get my coat.
You can't go home with me.
What?
You can't.
Oh, what? You can go home with me, but I can't go home with you?
No, no, that's not it. I just need to go home.
You live in an apartment?
Yes.
But they don't let black folk in there?
No. I mean, yes, of course they do. Look, no more jokes. I've got to go. I'm very tired.
All right, as long as you don't run into no hassle about getting me in there.
You're serious.
I think you know I'm serious.
You can't be serious.
I'm serious as a heart attack.
Why are you doing this?
Me? I ain't got no choice.
Of course you have a choice.
No, I ain't.
Who appointed you my guardian angel?
You know who appointed me your guardian angel. Now look, I ain't asked for you to jump into my arms down the subway this morning.
I didn't jump in your arms.
You did?
No.
How you get there then? What, now we ain't going?
So there are a lot of things that I see when I look at this clip, but I think that a few things are clear. One is that the person who is committing suicide or attempting suicide isn't always clear in their own minds why they're doing it and why that day. But they're usually in extraordinary pain, and I think you see that pain in Tommy Lee Jones's character. I think the other thing that you see, and we're going to come back to this as our presentation continues, is that a big part of what Lawrence Fishburne is doing is trying to keep him engaged, finding any way to keep him talking, to keep him participating, to keep him present, as opposed to leaving. And that becomes a very important part of how we manage suicidality. Today, I'd like to talk to you about some of the biological, diagnostic, and psychosocial risk factors for suicide, and then spend some time talking about which treatments may be effective either in mitigating or ameliorating suicidal behaviors. And finally, to talk a little bit about what may be the next step in the evolution of managing patients with suicidal behaviors. At the end, we are going to have a question and answer panel, and we'll be able to address a lot of your questions. So unless it's really urgent, let's hold it for the end. So I thought some definitions would be helpful. When we talk about suicide attempt, we're talking about a specific act of self-harm where the person intends to die and believes, they may not be correct, but where they believe that the method that they've chosen will be lethal. So someone who doesn't know a lot about pills and thinks that 5 acetaminophen are going to be lethal may be making a suicide attempt because in that belief they thought this was going to kill them. It's not about necessarily how lethal the method is, but what the cognitive state was of the person doing it. And we want to differentiate suicide attempts from things that we call non-suicidal self-injury. And non-suicidal self-injury includes things like cutting, burning, self-mutilation, headbanging, but where the specific intention is not to commit suicide. That doesn't mean that these individuals can't or don't escalate to more suicidal behavior, but at that moment, these behaviors did not have any suicidal intent. the primary intention of people who commit non-suicidal self-injury is to ventilate intolerable feelings of agitation and anxiety. What you won't see in the last slide is the term suicide gesture, because we no longer talk about suicide gesture, because quite frankly, we could never really agree on what it was, and there was a lot of overlap between the other two categories. So the way to think about it is, what was the intention and what's the outcome? So we're going to spend some time now talking specifically about who's at risk for suicide. And so we're going to look at some of the diagnostic issues, the genetic issues, some of the things that go on in their psychology and social environments, and then finally we're going to talk about a unified model for suicide. So this slide is interesting because it shows the changes in the risk for suicide over time. And what you can see is that in both men and women, the completed suicide rates have nearly doubled in the last 25 years. Now this increase, if you look at the slide on the right, you'll see that this increase occurs in every decade. And although the risk of suicide is greatest as you get older, the biggest changes that have occurred have had to do with the increase in suicidal risk among teens and adolescents. This trend is not just in the United States, but is worldwide. And what you can see here is that in 1950, and this is data drawn from 11 countries, 40% of the completed suicides were in adults younger than 44 years old. But by 1998, 55% were in adults younger than 44 years old. You know, because of the opiate epidemic, there's been a lot of focus on the number of people dying from opiate overdoses, and it has obscured a comparable trend that's occurred in suicide. That in the last 20 years, the number of suicides in the United States has more than doubled. It now exceeds the number of people dying from motor vehicle accidents. So we have to put this in the context of a serious health issue. In 1995, suicide was the fourth leading cause of death among adolescents. Today, it's the second leading cause of death in adolescents. There has been a 300% increase in suicides among adolescents. This is an epidemic. One of the things that we know is that the vast majority, the overwhelming majority of people who commit suicide have a mental disorder. This does not come out of the blue. You know, in fiction and in movies, there's a tendency to romanticize suicide as some kind of existential choice. It is not. It is a response to, at times, chronic and unremitting mental disorder combined with a really bad set of circumstances. When you look at which psychiatric diagnoses contribute most to suicide and suicide attempts, not surprisingly, mood disorders, major depression, bipolar disorder, are responsible or contribute in about 35% of the cases. Substance abuse is the second largest group at 22%, schizophrenia at 10%, personality disorders 11%. But what's interesting here is that no one diagnosis contributes more than 30%. And this is a theme that we're going to come back to, because we no longer think that it's meaningful to only look at this in terms of an underlying diagnosis. We think that schizophrenia, that suicide is a process in its own right. So all serious mental disorders are associated with significant increases in suicide. The risk of suicide is somewhere between 10 and 15% for major depression, bipolar disorder, obsessive compulsive disorder, alcohol dependency, and anorexia nervosa. More than 50% have never been admitted to a psychiatric disorder before completing a suicide. And a third of suicide victims die on their first attempt, meaning that we don't get a second chance. The other thing that's difficult to accept, and that I think for a long time we really hoped wasn't true, is that anyone who has ever attempted a suicide is at markedly elevated risk to complete suicide. The reason this is important is because there are 100 times more suicide attempts than completed suicides, so that we are looking for a needle in a haystack. Even so, there's a tendency to say, well, that was an attempt, it was a year ago, it doesn't matter. But the individuals who've gone as far as making an attempt remain at a chronically elevated risk. And while that risk is greatest in the first year to 2 years after an event, it never fully goes away. You know, one of the things that when I started to pivot my career toward addiction is how much suicide plays a role in alcohol and drug dependency. Suicide is a leading cause of death in patients who abuse alcohol and drugs. 1 out of 5 people who die by suicide has an alcohol use disorder, meaning an alcoholic. Patients with alcohol abuse or dependency have 10 times the risk of suicide than the general population. And while this risk is certainly weighted toward alcohol, it's not limited to alcohol. Intravenous drug users, most of these are heroin users, have 14 times the risk of suicide. And here's the startling statistic, which is that clients who enter treatment are at especially high risk for suicide. And we think that this is a combination of their underlying addiction and the myriad of circumstances that have come together to throw their life into complete disarray. So what do we know? We know that when there is alcohol use disorders present, that the suicides tend to occur at a younger age. So that when we look at statistics that talk about increased alcohol use in teen and young adult populations, we need to be concerned because this is a permissive factor in dangerous behaviors. The other interesting thing is that alcoholics who commit suicide do seem to have more events in their lives that seem to be acutely precipitating the attempt. Romantic breakups, arguments with families, close friends dying, these losses seem to play a bigger role when substance abuse is involved. And finally, a history of regression is predictive of suicide in alcoholics. So I think that, you know, in the past, we tended to think of suicide as a complication of a specific psychiatric disorder. We now have started to understand it as a panpsychiatric problem, meaning that it cuts across all of these diagnoses and that it may have its own cause separate and apart from the dysfunction that's contributing to the underlying psychiatric diagnosis. In other words, they may be fellow travelers, but not necessarily causing one another. Which brings us to a kind of stress diathesis model. The way this works is that there is an underlying susceptibility to an illness or a process. That's the diathesis. And usually there's evidence through genetic studies, epigenetic studies, and environmental studies that speak to an underlying predisposition or susceptibility to a particular illness or condition. And we're going to look at genetic factors that contribute to suicide, and then we're going to look at how there may be epigenetic factors such as environmental exposures that contribute. And finally, we're going to look at circumstances that may alter the psychological expression or brain neurophysiology in a way that makes suicide more likely. So what do we know about the genetics of suicide? So most of the data that we have today that speaks to suicide comes from twin studies. And in these studies, they typically compare identical twins who have every gene in common to fraternal twins that only share 50% of their genes. So if a disorder is genetic, it's going to appear much more often in the 2 identical twins than in the 2 fraternal twins. Does everybody follow that? Okay. And then when the sample sizes are large enough, and they usually aren't for suicide, because again, it's a relatively rare phenomenon compared to the population, and it's rare if you're looking specifically for identical twins, so it's not always easy to study. Then you can further tease this apart by comparing twins that were raised together to twins that were raised apart, to try to factor out environmental factors farther. So what you see is that in women, genetic loading accounts for about 3/4 of the risk of suicide. So if you're an identical twin and your sister committed suicide, the odds of your committing suicide is 75%. This is an extraordinary statistic. If you look at men, there appears to be a genetic contribution, but it is significantly less. And environmental factors such as job, relationships, physical injuries seem to play a bigger role. There's extensive research that's been done looking at the neurobiology of suicide, meaning changes in neurotransmitters and receptors in the brain. We don't have time to cover all of this tonight, but the most compelling evidence has to do with the serotonin levels in postmortem brains of people who were victims of suicide. And what you see is significantly lower brainstem serotonin levels. Norepinephrine levels are also lower in suicide, and the hypothalamic pituitary adrenal axis, the HPA, is significantly activated, such that people, particularly patients with depression, who attempt and complete suicide have significantly higher cortisol levels. And finally, there is a chemical called brain-derived neurotrophic factor that's an important protective and healing compound in the brain that appears to be low in individuals who attempt suicide. What I'd like to do now is to try to focus the discussion on adolescence and trying to understand what's different about adolescence and how these factors may be contributing to the significant increase that we've been seeing over time. So I mentioned before, it's the second leading cause of death in youth 15 to 19. You know, in adolescence, females make twice as many attempts as young males. But the attempts made by males are much more lethal. So that even though males are responsible for half as many suicide attempts, they complete suicide 3 times more often. So when you look at the situation, it's not like we can be concerned about one or not the other, but we need to recognize that as a proportion of the number of people attempting suicide, it's far greater in men. You know, there's a sense sometimes about suicide that if this is related to an underlying psychiatric disorder, and if it's tied to genetic risks, and if the predisposition doesn't ever fully go away, that there may not be anything we can do about it. And I want to say clearly and unequivocally that's emphatically wrong. This slide calls out one of the simple things that we can do that you can show that both on an individual basis and a population basis reduces suicidal risk, which is removing the most dangerous methods that are available to someone. In the United States, far and away, the most significant risk comes from firearms. And not having firearms in the house and removing weapons from the house is one of the most critical steps that we can take to reduce suicide risks. I can tell you that for the last 20 years, I have not been willing to treat anyone who is suicidal who is not willing to remove the guns from their home. Other methods of suicide have gotten more difficult. Before catalytic converters, it was much easier to commit suicide from carbon monoxide poisoning. It's no longer easy to do that because there's very little carbon monoxide left. Similarly, the idea of putting your head in a gas oven is very difficult because there are not enough toxins in the gas to actually kill you most of the time. So what we're left with are poisonings, and this could be overdoses, drugs, solvents, suffocation, and jumping. And in my experience, you know, some suffocation and jumping are very common methods in adolescence. You know, one of the common focuses in recent years has been around the effects of media and social media on suicide. And we're going to talk about those effects, but I really want to call out in advance that those effects are kind of different than we may believe. And so some of the things that we think are true only have weak effects, and some of the things that we don't think about very often may be driving this much more than we realize. So we're going to talk about clusters, we're going to talk about lethality, and we're going to talk about cyberbullying and regular bullying. So what can we say about clusters? So one of the things that's been known for decades is that suicide attempts in adolescence tend to cluster. That is, if someone makes a suicide attempt, their friends, friends, other people in the school may make a suicide attempt. And that this close proximity to the original attempt is what we call a cluster. And we think that media coverage may contribute to cluster suicides. so that the more media coverage there is, the more it's talked about in that way, the more aware other teens become and the more likely they may be to make an attempt. One of the things that's happened with social media and the internet is that the media coverage of suicide is no longer limited to your neighborhood. So if there was a time where you would not have heard about the suicides 3 towns over, you're going to know about them now because you subscribe to neighborhood watches, you're looking at things on Facebook, you're geolocated, so that this phenomenon that was largely local until the end of the 20th century is now much more diffuse. The other thing is that there have been good reports that suggest that even fictitious accounts in film and TV increase suicidal thoughts. But it's less clear if it actually motivates suicidal behavior. But when you survey teens who've watched TV shows or movies that include suicidal elements, that there is some evidence that the frequency of suicidal thoughts goes up. But I want to talk about lethality. You know, when I want to learn something, the first thing I do is I flip on my computer and I go to Google or to Wikipedia and I look it up. And people who are suicidal do the same. And one of the things that social media has done is it's made access to information about how to engineer a lethal suicide attempt much more available. And the result of that is that adolescents who come to us have spent a lot of time not just fantasizing, but actually reading about first-person accounts of how to take your own life, how to hang yourself, how to poison yourself. And this is very different than it was 20 years ago. You know, there's 2 ways in which the internet seems to play a role. One is that it increases lethality, that it's filled with advice. But the other is that it normalizes suicidal behavior, that it portrays it as free will and choice. And that's really opens the door. It gives permission and license to this by saying this is an existential choice. You know, don't let anybody tell you otherwise. So bullying is one of many social environmental factors that we know is connected to increased suicidal risk. You know, impaired parent-child relationships, breakups in the home, you know, placement out of the home in a group home or correctional facility, not working or attending school, stressful life events, and unsupported environments, particularly for LGBTQ youth, all are environmental factors that have been linked to increased risk for suicide attempts. But let's talk a little bit about bullying. So it's probably helpful to step back and make sure everyone is on the same page about the definition of bullying. So bullying is aggressive or deliberately harmful behavior between peers. So it's between similarly aged individuals. For it to be bullying, that behavior has to be repeated over time. This is not a one and done phenomenon. This is where it occurs again and again. And typically it involves an imbalance of power, and that imbalance of power may involve physical strength, because that's typically the case in young boys. A lot of it's about physical strength. But as people get older and mature, it could be about popularity, it could be about money, but it's also the ability to control your peers. There are different types of bullying. There's direct physical assault, there's intimidation, direct verbal threats, insults, name-calling. Then there's indirect relational bullying, social exclusion, the spreading of rumors, and finally there's cyberbullying. So what do we know about the relationship between bullying and suicide attempts? Well, it turns out that both the victims of bullying and the perpetrators are significantly more likely to attempt suicide. You know, this is probably because most of the people who engage in bullying are struggling with their own, often undiagnosed psychiatric disorders. So that, you know, when we intervene, we have to look at both sides of this equation if we're trying to help this from a mental health perspective. Cyberbullying is very disruptive because it introduces anonymity into the process. That before cyberbullying, it was not an anonymous practice. You knew who was bullying you. You knew who was starting the rumor. You knew what was going on. Now, it's anonymous. It seems universal. There's no good way to stop it. And I think that cyberbullying is a significant change that is contributing to some of the hopelessness and suicidality that we're seeing. I'd like to pivot and talk a little bit about treating and preventing suicides. When you start a psychiatry residency, by the way, I'm a psychiatrist, not a psychologist. One of the first things they teach you is how to interview someone who you think may have suicidal thoughts, which in psychiatry means anybody that you see. You realize that you share the same bias as the rest of society, that you're afraid to ask people directly about their suicidal thoughts and whether they've made suicide attempts. And I'm here to tell you that nobody jumps off of a building, cocks a gun, or takes poison because someone asked them if they were suicidal. The best and most reliable tool we have is a conversation in terms of assessing immediate suicidal risk. And the only way to ask about it is to ask about it directly. And most of the time, the person who is suicidal is going to feel a sense of relief because they are having these thoughts, they are ashamed of them, they're afraid to talk about them, they're severely anxious. And when you open that door, you give them permission to have this conversation. So it turns out that, suicidal behavior is notoriously difficult to study. First of all, you can't withhold treatment from suicidal people. So that one of the challenges is you're never going to get like a placebo group. Retaining and recruiting subjects is virtually impossible. In other words, putting out an ad in the paper the way we do if we want to study depression or panic disorder or hypertension, saying, if you have hypertension, call this number and you could be in a study. It doesn't work for suicidality. And that more importantly, completing the study is difficult because of the risks involved. The other problem is that suicide itself is very infrequent relative to suicide attempts and self-harm. So that when we try to understand suicide, we don't really know how far we should extrapolate from self-harm and suicide attempts. Now, one of the things that we do know is that people who have made suicide attempts are significantly more likely to attempt suicide again. And it turns out that people who repeatedly engage in self-harm are also more likely to make suicide attempts, although not in the short term necessarily. Finally, it's very difficult to reach conclusions about suicide effects of drug treatments because most drugs that we give in trials, we give for a very short duration. So to get an antidepressant approved, you might have a 12-week acute phase and then a 6-month extension. And that simply may not be enough to really fully understand the effects of a drug, either in protecting against suicide or in making suicidal risk worse. Does that make sense to everyone? So when we think about, well, why don't we know more? I think part of it is the inherent nature of this problem. So the question becomes, why are we spending so much energy trying to make suicidal behavior and self-harm the focus of treatment? And so as a reminder, the first reason is because we know that it's not tied to a specific diagnosis. And we know that the genetic factors that contribute to suicide segregate from the genetic factors that contribute to depression, anxiety, and schizophrenia. In other words, that when you look at the pedigrees in these families, suicidal risk can be inherited separately from the other disorders that may run in that family. The second reason is that suicide risks remain high for long periods of time. And this is true even when the underlying symptoms resolve, that those same people remain at an elevated risk to make a suicide attempt. So if all we do is study this in the context of the disorder, we would say, well, you know, they're better from their depression. We don't need to worry about this. Finally, many psychiatric problems are episodic, but the risk for suicidal is persistent, genetic, and epigenetic, and doesn't go away in the same way as acute psychiatric symptoms. Now, there are protective factors that do reduce someone's risk for suicide. Reasons for living, I hate that one. Clean and sober, attending support groups, religious beliefs against suicide, child-rearing responsibilities, intact marriage or relationships, trusting relationships with a counselor, doctor, or other care provider, employment, and looking at the bright side of life. The problem with these protective factors is they cannot be relied upon. You can't look at someone and say, well, they're married and they're employed, and say that their suicidal risk is therefore low. So although it is generally helpful to think about these in terms of handicapping risk, one should never rely on these things to make a decision about what level of care someone needs. And I think that the other factor about protective factors is that the vast majority of these things are outside of a provider or teacher's or guidance counselor's control. Whether someone has a reason for living, whether they're clean and sober, all these things transcend what happens in that assessment and in that office. So the rate for suicide worldwide is 13 per 100,000. Twice as many men who attempt suicide complete suicide compared to women. So what are the warning signs for suicide? Suicidal communication. You know, most people who are thinking about suicide don't talk about it to everybody they know, but they frequently talk about it to someone. They may talk to their family doctor, they may talk to a teacher, they may talk to a friend. So that if you're in any of those capacities and somebody is talking to you about suicide, you have to take it seriously. You have to tell someone else. You need to recruit reinforcements. Because this is a bigger problem than any of you can deal with on your own. It's a bigger problem than I can deal with on my own. So threatening to hurt yourself or kill yourself, talking about wanting to hurt yourself or kill yourself, you know, reading books about suicide, talking about online suicide sites, all of these things are signs that someone is really starting to give consideration to ending their life. If you were to try to rank how this escalates, probably the next step is seeking access to a method. You know, I always ask people, have they gone shopping? In other words, have they bought ropes? Do they own a gun? Have they accumulated pills? Because very often people will do these things months or even years before they actually make their suicide attempt. So it's not that they haven't done this before or they haven't considered it. They frequently have prepared for it and planned it. Finally, writing or talking about death, giving away possessions, giving up the apartment, these are less likely to be seen in adolescents. But saying goodbye to friends, you know, telling people you're not going to be seeing them for a while, those things are pretty common. So I'd like to spend a little bit of time talking about biological treatments. You know, the cornerstone of treating people with suicidality is not a pill. You won't find safety in a medication bottle any more than you'll find safety in protective factors. But we have learned something about medicines that can make a difference, and I wanted to call them out because I think they're underutilized. Probably the strongest and most compelling data we have is for lithium carbonate. Lithium, until about 15 years ago, was the unequivocal treatment of choice for bipolar disorder. And what you can see here in this slide, if you just look at that last column on the right, is that there is a highly significant reduction in suicidal acts among people with depression and bipolar disorder on lithium. And that's true whether it's bipolar disorder or major depression. It's true whether you measure attempts or completed suicide. No matter how you measure it, lithium is significantly more effective in reducing suicidal risk than anticonvulsants or atypical antipsychotic drugs. So that I bring this up because very often Families who wrestle with depression and who have bipolar disorder are resistant to lithium because it involves blood tests and monitoring and more frequent doctor appointments, but there is a role for lithium. Because antidepressants are so widely used today, and I say antidepressants, I'm talking about things like Prozac and Paxil and citalopram and Lexapro and Effexor and all of those, but they're classified as SRIs and SNRIs, are used so widely. And because the vast majority of these prescriptions are given by primary care doctors, pediatricians, internists, GPs, gynecologists, I think it's important for us to try to understand the context because there have been a lot of articles written about the relationship between antidepressants and increased suicidal risk, particularly in adolescents and young adults. This slide just shows you the risk, and to the right is good, to the right is bad and to the left is good. So when you look at it by age, so if you go down the rows, you start at less than 25 years old, you go to 65 years old. And what you can see is that there's only one age group in where there is an increased suicidal risk, and this is about attempts, not completed suicides, and that's in adults and children less than 25 years old. And that effect is fairly substantial. There is a significant increase in both suicidal thoughts and suicide attempts in that age group. And so when one is going to use antidepressants in young adults and teenagers, they need to be monitored more closely than you monitor adults. Because in adults, it is reasonable to expect and to predict that suicidal risk will actually go down, not up. This risk appears to be clustered in the first 3 to 4 weeks of treatment. So it isn't that antidepressants may not be an appropriate treatment, because after 3 or 4 weeks, the suicidal thoughts tend to abate, the risk goes down. But it just means that it requires a different set of constructs to figure out how often you're going to see them, how long, and what else you're going to do. You can't just send them home with a prescription. So in adolescence, medicines like serotonin antidepressants increase the risk of suicidal behaviors. In adults, there's no increased risk. Age may be a factor all the way to age 25. But in adults older than 25 years old, antidepressants actually appear to have a moderate protective effect. Now, one of the things that makes suicide risk so difficult in teenagers is that all of the major psychiatric conditions seem to really get going in adolescence. So bipolar disorder typically has an adolescent, early adulthood onset, major depression, anorexia nervosa, substance abuse, and schizophrenia all have their peak onsets in adolescence and young adulthood. So the backfield is in motion, and in many instances, parents have not had to deal with this before. It is a new problem and a first presentation. Even so, I wanted to spend a little bit of time talking about schizophrenia because in this particular instance, clozapine, which is a novel antipsychotic drug that requires very close monitoring, clearly and unequivocally resulted in fewer attempts, fewer hospitalization, and fewer rescue interventions. And this is compared to all other antipsychotic drugs and compared to the most similar antipsychotic drugs. Again, I think if we're serious about trying to treat suicide, we need to think about drugs like lithium and clozapine differently because of their anti-suicidal properties. So there have been a number of studies trying to look at psychotherapy and its effects on suicide. Different studies have used different measures, and we've talked a little bit about the problems involved. We know that suicidal ideation and suicide attempts are different than non-suicidal self-harm. But in many studies, all of these things are grouped together. So it's not possible to know which subjects had one, which ones had the other. Many of these studies are short-term studies. So they studied people for 8 or 12 or 16 weeks, but remember, suicide risk stays markedly elevated for at least the first year following treatment. And then although it goes down, it doesn't go to zero. So a major criticism of all the studies having to do with therapy has to do with the fact that they were too short to really recognize and understand their value. Even so, two therapies seem to be the most promising for reducing suicidal ideation, particularly in people with mood disorders. And I'm going to spend just a little time talking about dialectical behavioral therapy, or DBT, because it's the major focus of the Aspire program that you're going to hear more about when we start the panel discussion. So there are 4 components of DBT: distress tolerance, emotional regulation, interpersonal effectiveness, and mindfulness. Mindfulness is a general tool for reducing and managing stress better. It's a way of staying present without feeling you have to respond to the fireworks going off all around you. Distress tolerance is really about acquiring the tools needed to be able to handle everyday life stresses better. Interpersonal rejections, breakups, disagreements with peers, problems with bosses. Emotional self-regulation is important because one of the things that you see in people who are prone to suicide is difficulty in kind of getting back to normal, bringing themselves back to feeling okay. And finally, interpersonal effectiveness. What can I do that makes me more effective in managing the problems that I face? Most of the time, DBT is offered around a 16 or 20-week type program, sometimes as short as 12 weeks. And there tend to be both individual and group components to both teach and acquire these skills. Recently, though, there's been increased focus on looking at using technology and brief interventions to try to reduce suicidal risk, because it's pretty clear that we simply don't have enough therapists in the universe to manage this level of population problem. In other words, if you're trying to respond to a 300% increase in risk, you've got to find other tools that you can pair with DBT programs and individual therapy to try to manage risk. So in one study called the SIAM study, they used a letter or postcard to contact people who had made suicide attempts and people who were considered at risk based on suicidal thoughts. And there was a follow-up study that then used text messages at regular intervals. And both of these studies found that there was significantly more engagement and decreased suicidal thoughts in response to these very brief contacts. And one of the thoughts is that it reminds the person that there are people available that they can reach out to get additional help. That it reminds them that they have this relationship to someone who cares and who can intervene on their behalf. So we've talked about different methods of psychotherapy, and we've talked about intense interventions, and we've talked about low-intensity interventions. But the thing that I really want to emphasize is that a trusting relationship with a counselor, with a doctor, with a care provider is the only protective factor that's directly under the control of someone who provides treatment. It all starts there. And if that relationship is failing, then we're failing in our job. And this slide is interesting. This looks at the effects of treatment participation on suicide attempts across a range of problems. So what you have here is patients with 0 risk factors, 1 risk factor, 2 risk factors, and 3 or more risk factors. And risk factors include an underlying psychiatric diagnosis, a recent psychiatric hospitalization, medical problems, substance abuse issues. So if you stack those problems, the first thing you see is that the more risk factors someone has, the more likely they are to attempt suicide, which is not surprising because that's how these factors were derived. But what's really compelling about this slide is no matter how many problems you have, treatment participation dramatically and significantly lowers your risk of making a suicide attempt. So for every problem level, engagement is the primary mechanism we have for reducing suicidal risk. And this gets to one of my long-standing concerns, which is that both patient and family and often providers are very eager to, quote, put the suicidal risk behind me. They want to, it's sort of like blue skies shining on me, nothing but blue skies do I see. And as the person improves, everybody breathes a collective sigh of relief and wants to believe that it was only a phase. And the truth is, most of the time, treatment is too short. It's not that it needs to continue at the same level of intensity. It's that we need to make sure that it continues, at least for the first year, and probably for the first 2 years. That even if we're not talking about weekly visits or even monthly visits, that the person maintains enough regular contact with someone that they trust and that they have confidence in, that if the crap hits the fan, that they're going to be able to reach out and get more support. So just to summarize, medications can potentially play a role in reducing suicidal risk, particularly lithium in the case of mood disorders and clozapine in the case of schizophrenia and other psychotic disorders. Specific therapy outcomes may have to merge with a model of connectedness and relatedness that encourages access to more intensive help. So we can't sort of divide this into weekly therapy and then no treatment. We need to look at ways to keep people engaged and connected. Session duration, session frequency, and session medium, meaning live, text, video, postcard, may be less important than treatment continuity and reciprocal commitment, that the person makes a commitment to being involved with it and the clinician makes a commitment to be available for it. And finally, we are in many ways still at the very beginning of understanding suicide. And the current epidemic has really forced us to focus more in this area. And so things that we wish we understood better and wish we knew with a great deal of confidence, we still struggle through. But we are infinitely better today and infinitely better equipped to identify and manage these problems when they occur than we were 25 years ago. Thank you.
Dr. Sack. Are there counselors up with us? If you filled out a card when you came in, if you can just pass it to the ends of your row, and then if someone can just bring them up and drop them at the stage, then I'll grab them. I left some empty ones just right up here by the stairs on the second level, and I can have you come over to the And joining us up here is Stacey and Celia, and they're marriage and family therapists, and I'll ask them just to introduce themselves quickly. Welcome.
So my name is Stacey Cervantes. I'm a licensed marriage and family therapist at the Hoag Hospital Irvine location. I have a history of working with teens for a while, for several years. Before I was here, I was working at a non-public school as a school therapist, so got an opportunity to really understand the IEP and special education aspect of adolescents and children. And then was also at Hoag Hospital, Costa Mesa for a while, and had the opportunity to work with some of the co-occurring disorders of substance use, schizophrenia, bipolar, those sorts of disorders. So.
Hi, I'm Celia Quinlivan. I'm also a licensed marriage and family therapist. I'm one of the therapists in the Hoag Aspire program in Newport, and my background stems a little bit on the trauma end. I worked with victims of crime and human trafficking, and then after that I worked with kids in foster care and adoption, so I have a background in working with a lot of trauma and attachment-based issues that lead to a lot of substance use and behavioral problems, depression, anxiety, and PTSD, and now I'm with Hoag too.
Thank you. So the first thing that I thought about when Dr. Sack was speaking was it reminded me a little bit about when we do threat assessments with the Sheriff's Department. So they kind of have a profile of what these young people look like, and it raises the risk factors and sort of gives them an idea of sort of like the threshold of where they're at. Is that in some ways the same as far as suicidal young people, or is it more complex than that?
Well, I'm not sure how reliable either assessment is, so I think that's the first problem. But I think that one of the problems with suicide is that you can have youth that are very well adjusted, highly successful, who then enter into an episode of depression with or without a precipitating event or trauma and become suicidal, whereas the pre-morbid personality style and patterns of adjustment of people who are, serious assault risks is very different and usually longer standing. They've had lifelong problems with adjustment and adaptation. So I think that suicide is harder because it can in fact come out of the blue. Very often there may be a period of depression or anxiety or withdrawing from friends, but it isn't the same sort of pre-morbid adjustment issues that you sometimes see with these other conditions.
Yeah, I would add to that, and this is kind of going going with what he's saying. A lot of the teens that we see are very high functioning. They're 4.2 students, they're varsity athletes, and sometimes the students who kind of have it together are the ones who are just filling their time because they are struggling. So it may not be your typical or stereotypical depression, isolation, and so that's why it's a little hard sometimes to know when our teens are struggling. So it is important to be checking in with them.
And I would say, just kind of in reference to what they're both saying, is that's why it's so important to have these conversations and ask, because you never know what might be going on. And the symptoms look different sometimes. Sometimes, we get teens that are just feeling irritable all the time, and that's one of the biggest signs of depression, and a lot of times they are also struggling with suicidal thoughts. So that's where, asking and being direct, as Dr. Sack was saying, and finding out what's going on is so important. I know that before we started answering the questions, we just wanted to tell you guys a little bit about the Aspire program. I know Dr. Sack kind of mentioned it several times throughout the presentation, and we'd be happy to answer any further questions you guys might have after. But just kind of an overview of the program. We are an 8-week dialectical behavioral therapy, or DBT, outpatient program. We program 4 days a week, and we help teens that are struggling with anxiety, suicidal thoughts, self-harm, depression, things like that. And we do incorporate parents as well. So we have a multifamily component twice a week where parents come in and they're learning these skills alongside their teen on how to decrease their stressors and their emotional reactivity to things that come up and develop those healthier adaptive coping skills. So.
Thank you. So the first question is, how and what are the tools told to someone who is self-harming to stop? Are there support groups for kids between 20 to 25 for self-harm and suicide prevention?
Yeah, so some of the tools that we talk about, again, are just kind of finding more adaptive or healthy coping skills. So whenever we encounter someone that has been self-harming, they're using that as a coping tool. They're using that to deal with the emotional things that are going on inside. And so we always want to find, okay, what's a replacement that's not going to make this situation worse? And so some of those things, are going to be different for different people. Some people really enjoy, using mindfulness activities such as, progressive muscle relaxation, things like that. Other people really like intense exercise to distract for a while. So those are just a couple examples of the skills that we talk about and that are out there.
Yeah, I think the other thing about cutting is that it's frequently cutting, it's not always cutting, is that it's often a way of communicating distress. That the problem isn't the cutting at those times, but the underlying distress and desperation that person may be feeling. And many years ago, I had a patient, she was bipolar, early 20s, and really cut on herself every week, hundreds of cuts on her wrists every week. And then one day she came in and she had cuts on her face, and I looked at her and I said, you have to go to the hospital now. And she looked at me, she said, Dr. Sack, I've been coming twice a week for a year. I cut on myself all the time. why am I going to the hospital now? I said, well, if you cut too deep, then you're going to sue me, so you have to go to the hospital. But the point I'm trying to make here is that it wasn't the dangerousness of the behavior that drove that decision. And frequently cutting is not in and of itself dangerous, so that it's really that it's a sign of a more serious process that's going on. So the reason I bring this up is that nobody likes to see blood on the floor. It's very disturbing. You see this at addiction programs all the time. People scamper about and get all excited and nervous about it. But the key is, what's the intent? Is this part of a suicide attempt, or is this ventilating rage and anxiety? And how do I respond to this communication of somebody saying to me, I'm out of control, I feel really, really bad?
And just to add to, obviously talking to someone is really helpful. And now sometimes we can't always see maybe a therapist immediately or, get to a hospital immediately. So if you are noticing that maybe your teen is cutting or, engaging in any kind of self-harm, removing those things from their rooms or the home is really important. I know I've talked to parents who sometimes think maybe it's extreme to even, lock up kitchen knives and things like that, but we want to take this really seriously. And so just removing anything that can be harmful is really helpful. And also, I can't emphasize enough, coming from an empathetic place with, the person who's struggling. I know sometimes that can be really startling for a parent, and parents can sometimes be really reactive. So really coming from a place of concern and empathy can go a long way with helping your teen open up, and even younger, even children as well. Because I've seen self-harm with young children, 5 years old.
I did want to also address the question because I was asking about 20 to 25-year-olds, correct? So we are actually in the process of hopefully opening up a transitional age youth program that would be somewhat similar to Aspire for primary mental health. Unfortunately, there aren't a ton of programs that are primary mental health for adults 18 to 27. But if you would like to give us a call, we can provide some referrals. In the meantime, for even some individual therapists, we're always open to doing that for anyone that calls.
Yeah, I was going to mention, outside of a program, I would say the next thing then would be just seeking a therapist or counselor individually.
Yes.
Is there ever a time when you can tell the difference between students who are talking about these issues or maybe mentioning that they are feeling suicidal, but it's more attention seeking than it is an actual risk?
So, kind of how we address that, because we get that question a lot, usually from parents, and we take it seriously either way. If it is attention seeking, we still need to look at what's going on, why are they seeking this attention, especially in this way. So regardless if it's attention seeking or it is leaning more towards those suicidal thoughts, we still need to take those things very seriously.
So if a 10-year-old, say, doesn't get their way and says, I just want to die, what do you say to parents?
I think that most 10-year-olds, even when they're really angry with their parents, don't say, I want to die. So I think we have to recognize that even in the statement, you're already outside of the norm. That doesn't mean that they want to kill themselves, but it is really a statement of desperation that transcends, what most 10-year-olds get to. So I think it really warrants an evaluation, and I think it's very hard for parents. The other thing is that developing an ability to tolerate self-harm if the person's in treatment and they're doing other things to help themselves is important, because one of the things that happens when people cut on themselves is they get rejected. Nobody wants to put up with it. It's gross. The parents feel anxious and threatened. Their peers don't know what to make of it. It's so that part of this is how do I acknowledge it and manage it without resulting in rejection or alienation, so the person can be part of a treatment process.
I would also say that we've definitely seen threats like that, and it's turned into kind of a manipulation. Either way, again, just going off of what Dr. Sack was saying as well, we still want to see why this is kind of the outlet of that manipulation. what's going on to make this be that go-to statement or go-to threat, and getting that evaluation.
The subject of someone harming themselves comes up often with my 16-year-old. I'm not sure how seriously to take this as it seems so common, so conversational.
I would definitely say that if a teen is expressing any kind of suicidal thoughts or any kind of self-harm, it is really important to go seek some professional help and maybe give that teen a space to talk to someone. I kind of call it like a neutral party, because sometimes teens are more willing to talk openly to someone who they don't have a direct connection with in terms of like family or friends. So sometimes that's really helpful. So I would definitely take that seriously and see what's going on, because they may be struggling with anxiety or depression and may not know how to label that for themselves, and so it may be coming out in ways of just wanting to hurt themselves or worse.
And if it's not specifically about them talking about their own self-harm, but just a subject in general, just a theme that they talk about or in conversation.
So I think I would, again, be kind of more direct with that as to why that's the conversational piece, if they are having thoughts about that, if they have friends that are engaging in self-harm behaviors. I would say that there's obviously something else behind that, if that is a continuous, ongoing conversation. And so just to ask about that, and if the teen isn't willing to talk about it, again, going to that third party and maybe getting another view of the situation.
Yeah, I think the simplest question is, well, why is it on your mind now? Is there something that is making you think about this more? And very often there are. It could be a TV show, it could be a friend's suicide attempt, but there's something driving it. And sometimes it's just an internal change in state, more anxiety, more desperation. Again, remember, serious mental disorders start at this age. And so they're experiencing things differently than they have before. Some of that is normal adolescence, but some of it is not. And so, I think asking the question is really giving permission and license to talk about it.
This question is, do you know any books for children or older elementary, tweens, or teens they can read about how to deal with friends who talk about suicide or suicidal ideation?
I think that this is one where you pull the emergency brake and you try to find out what's going on, both for the friend and their parents, and then try to get help for that family and individual. I think it's really unrealistic to think that we're going to inoculate a child of 10 or 12 against the feelings that are evoked by suicidal behavior. On the other hand, being in their own therapy can sometimes help them separate their own experience from a friend's experience.
I would also add, just in general, as we're talking about this and we're referring to going to see a therapist, making sure that the therapist is, I guess it's a specialty. So working with teens, children, that's a specialty. So making sure that the therapist that you're going to see is well versed in how to relate to that population. And again, we're happy to always provide referrals if you are having a difficult time finding someone that's a good fit.
If a banana has mood-enhancing effects, imagine what a whole food, plant-based nutrition can do for a depressed individual. Are there any thoughts to include a dietary component to future treatment modalities?
So nutritional supplements and dietary changes have been extensively studied now in many forms of depression. And really, with only one exception, has any of it really made a difference. And this is whether we're talking about St. John's wort or other amino acid supplementations. And the exception has to do with tryptophan, which is that you can show that diets that are experimentally depleted of tryptophan result in relapses to depression. And we know that suicides are associated with low serotonin levels in the brain, which is what low tryptophan does. But I think that it's a stretch to think that nutrition by itself will substantially alter the course of these behaviors and conditions beyond what we've learned so far. Malnutrition is certainly not a health. Poor nutritional status, parental neglect, and abuse are all factors that increase the risk of a suicide attempt. But I think to think that we can solve this simply through diet or that we could significantly move the outcomes is probably unrealistic, at least based on what we've seen so far today.
I would just also add for DBT in general and kind of how we approach just teaching skills is everything in a balanced way, right? So I actually just taught this group, I think last night, on balanced eating, balanced sleep, all of those things that does contribute to our emotional vulnerability if we're not taking care of ourselves. I would agree definitely that nutrition in and of itself, sleep in and of itself aren't going to necessarily make a huge impact, but again, bringing it back to that balance and making sure that we're coming at it from all aspects.
And these two are more school district related, but as I answer them, then I would also ask if you have things to add, please do so. So what is the school's responsibility when a student is reported as suicidal or self-harming? I will tell you, we invest as a school district over $4 million a year in counseling and other supports for students in our schools. We're one of the first districts to have counselors in every school in the district. With that said, our counselors and psychologists they're seeing, or they could see if they saw every student, over 200 or 300 at a time. So, when we talk about resources and things for teens, one of the things we also show them is signs of suicide. And it's not just for them, but for them to look for those behaviors or those things in friends, and then possibly report things that are concerning to them too. If a student is reporting directly to us, our responsibility is to support the student immediately and get in contact with the family to see what else we can do. If it's a situation where this question is reporting to authorities, if there are threats or other things involved, yes, we report to the authorities and do that work too, but that's not always the first thing we do. It's figuring out what other supports we can give kids, and then partnering with families or guardians to figure out what supports we can find outside as well. And in those situations, unless the child is 18, we do notify the families and guardians. That is part of the work we have to do.
I would also add that they're putting together presentations like this to bring awareness and open that communication. I know that you guys have been great with having this panel. There are some other school districts that are also following suit, which is awesome. So,
in a situation where a student has reached out through texting or email, and it's on a weekend, then in those cases, sometimes we will report directly to law enforcement if it looks like it is an immediate threat, and they will make contact with the families and try to contact the student. But it's always done in partnership with the families. It's not done individually or in secret with just the student.
I think too, it's really great, like Cecily was saying, is just having presentations like this and doing education on it. I think for a long time there's been a lot of stigma around mental health, and I think we're slowly making breakthroughs with that. And I think as we keep breaking stigma down and having more open conversations, it's going to feel a lot safer for people to be able to talk about it when they are struggling versus having that internal struggle and not feeling like they can reach out to anyone. So I think it's really wonderful when the schools are opening up those conversations rather than pushing them aside, because I think it really does create a safe space for a lot of our teens, and I know some are really appreciative of that.
If insurance does not adequately cover treatment, what resources are available for youth?
I know for our program specifically, if we are an insurance-based program, however, if coverage does fall through with the insurance, we do have philanthropy funds that do cover the rest of programming, because we do want to make sure that teens are getting everything they can out of our program without any fear of getting dropped. I know that there are a lot of different clinics out there. I know there's a lot of Medi-Cal clinics that have wonderful mental health services. If you have Medi-Cal, there are some therapists who also do sliding scale fees, which is really great. And I don't know off the top of my head some of the clinics, but I know that there are some free resources for mental health services.
And again, you can always give us a call or email us, and we're happy to provide you our referral sources. We have a pretty great list of clinicians who are really willing to work with families. So.
In Orange County, you know, the Medi-Cal system is sort of organized differently for mental health than it is for general health, and so there's sort of parallel systems. And Orange County directly funds, you know, children's treatment programs and assessment programs, substance abuse programs, wraparound services, and group homes. And many years ago, I had a number of these programs that were funded directly by Orange County. So I think there are services out there, but you need to go through the Orange County intake process as opposed to just, you know, calling the provider to access those services.
I would also just recommend reaching out to the principal of your school or to the counselors, and they would help give you resources and referrals for that as well. And if you don't have access to them, contact the district directly, and we can help you with that also.
I would just also add that if you're having a hard time finding someone that is in network with your insurance, Psychology Today is a really good resource. It's psychologytoday.com, and you can filter based on your specific insurance. So.
Okay. Just two more questions. You mentioned SRIs and the fact that seeing a psychiatrist or a counselor when using those, especially in the first 4 months, is important. So would that be a recommendation?
So there are really two thoughts here. One is, you know, child psychiatry is a specialty. So just seeing any psychiatrist is probably not enough. But seeing a psychiatrist who works with kids, even if they're not board eligible or board certified in child psychiatry, may still be preferable to relying on the psychiatric judgment of a pediatrician. Not because they're not well-meaning or that they don't know the side effect of these drugs, but they're less likely to schedule frequent follow-ups, to monitor the progress, or to note changes in behavior that would indicate a change for the worse or increased suicidal behavior. So there's really two issues. One is who's prescribing and monitoring it, and then the second issue is how frequently. So if we say, well, you know, really an expert should be the one who's prescribing and monitoring it, I think that's a really good first step. And I think that the second issue that I take with both my colleagues and others alike is they're not seeing people often enough. That telling them that since the medicine is unlikely to work for 4 or 6 weeks, you don't need to come back is the wrong answer. The right answer is, we're going to monitor you for side effects, make sure it's agreeing with you, we're going to make sure nothing is getting worse. Seeing someone more often is the best tool we have for improving safety, whether they're in an intensive program like Aspire, which provides services, 4 or 5 days a week? 4.
So we're 4 days a week.
4 days a week. The key is that frequent contact and frequent reassessment allows us to catch things that may be getting worse.
I was just going to add for our program specifically, we work with Dr. Sina Safaya, who is a double board certified child and adolescent psychiatrist. And he does monitor, you know, if there are any medication changes or additions throughout the time in the program. And so that's a really great aspect to Aspire as well.
So my last question then is, let's say you're a parent or a guardian of a child who you want to go to counseling. What does that conversation look like for a young person who might be embarrassed or scared or anxious about that? What does that look like?
So I would say that for the most part, teens that we work with anyway, and in my experience, is that they want help, they want things to change, they don't want to feel like they're feeling anymore. And so that is just basically a conversation, you know, and again, approaching it like Celia was saying earlier from that empathetic standpoint of, you know, I'm worried about you and I want to make sure that we're doing everything that we can to make sure that you're as successful as you can be, and really just in a sense of emotionally successful and feeling better. So generally they're open to that. Would you add anything?
Yeah, I would definitely agree. I think just, again, having the conversation, just because we're not talking about it doesn't mean it's not happening. So I really encourage, checking in with your teen, and, teens are looking for support. Try and reach out to someone who you feel comfortable with. Maybe we found that sometimes teens have a hard time asking their parents. Maybe parents aren't supportive. And so maybe it's trying to figure out, okay, who's maybe an adult in my life that I can reach out to. Maybe it's a school counselor first. Maybe it's a teacher who can maybe help support to facilitate that conversation. I know that's been helpful for some teens in the past that I've worked with. I would also say in the state of California, over 12, you can consent to your own treatment if you are within the right mind frame to do that. So that is something too that you can seek out, and hopefully your school can help support you in finding a counselor that could be beneficial.
I would just add that, good treatment takes time, not just on the part of the child, but on the part of the family. And so being prepared for that sacrifice helps to recognize that, taking kids to appointments, picking them up, having the conversation there and back. Honestly, I think sometimes that conversation in the car on the way or back is the most important conversation of the week for a lot of teens that are in trouble and need to talk about their feelings. So, and I think the other thing is that it runs the whole gamut, how teenagers respond to the suggestion of therapy. Some are phenomenally relieved. They have been struggling with this. They are in terrible pain. And any lifesaver they'll grab onto. And there are others who feel that they have to carry the success of a family. They may be in denial. They may have been the one who it looked like was going to escape the family curse. Many of these disorders run in families. And so they're tremendously angry about now being in a position where they need a kind of help that they thought was not going to touch their lives. And I can tell you can have two sisters with the same condition where one is only too happy to go to talk to whomever is made available to them, and the other one is thinking not now, not ever, because they have different views of their conditions and their need for help.
Just also kind of adding to what you were saying about the parent component, the most successful completions that we see in the programs are the families that have really been there and supported the teen. We don't view it as, there's the teen's the problem. There's something going on that is contributing to these issues, and if the parents are able to really be there and support and learn those skills alongside their teen and engage in those skills with their teen, then those are the most successful cases that we definitely see.
Well, I want to thank Dr. David Sack, Stacelyn Cervantes, and Celia Quinn-Levin for being here tonight. Fantastic presentation. And this is the third of 4 this school year that we'll have. The next one is scheduled for April 1st at Tesoro. It's Teen Mental Health Overview, and we'll have Dr. Sina Safaya back, who's the director of Hoag's Aspire program. For more information and resources, please talk to the panelists. Afterwards, they will hang around for a few minutes if you have more questions that you didn't want to address up here with the panel. And visit cusdinsider.org. We always have information there. That is our news source as a school district. And we will, as we are closing out this year with the Teen Mental Health Program, we will be looking at the next school year to see what we are providing in partnership with our families there. So again, I just want to thank you tonight for being here and invite you to talk to the panelists as we end. Thank you very much.